as those who have attended, since 1998 was the first one, I always have put together the 10 trials of coronary intervention. Have they changed my clinical or our clinical and interventional practice, or maybe some controversy? Some of them you'll see there will be a controversial, and I always pay tribute to Andres Grundtvig. Because of him, we are here, counted as father of angioplasty. Dream was catheter-based percutaneous treatment of vascular disease in alert and awake patient. So remember, see one, do one, teach one. And that is the whole focus of interventional cardiology. Those will be the 10 cases will be done today and with everyone's input. And what I added in this part is basically with utmost safety, appropriateness, because what we do has to be appropriate, not that there is a lesion, you fix it. And this will be a lot of discussion in our live cases and ambulatory. As you know, more than 60% of cases are discharged same day at present. So goal will be present the data which have changed some of our practice, and I'll bring it to in the end. I start with the first one with the mechanical circulatory support in cardiogenic shock. There are 3 trials as seen here. We have the balloon pump, PTVA, Impala, and CardioHelp, which is the portable ECMO available in the cath lab, and all the trials have been done. There are 2 trials of the ECMO. The first one was the Euroshock trial done in Europe, and basically goal was cardiogenic shock patient, whether ECMO helps. And this was a small trial with a 30-day mortality and 1-year mortality, as you can see here, 35 patients, and identical outcome with at 30 day as well as 1 year. So no difference in, rather higher bleeding and vascular complication. Then there was a bigger trial done in Germany and other countries of ECLS shock. Also again cardiogenic shock, now more patients, 400 plus, and randomized to same ECMO versus randomized to control group, and they have 30-day endpoint only, and identical, no difference in death at 30 days. You see that now. Even in this day and age, our 50% mortality. Remember the original shock trial, what was 30-day mortality? It's still 50%. So we have not done much in terms of mortality of cardiogenic shock. Some cases, of course, with the cardiogenic shock algorithm and so, but overall still remain 50% and clearly higher vascular complication. Then at least one positive note is using Impala. It started with originally from the Denmark, but because of poor enrollment, they got other countries, Germany and UK, called Danger Shock Trial. And this is a trial also, good number of cases, 360, just to say. It takes about 5 to 7 years to enroll 300-400 patients. And basically what it showed, that standard of care versus microaxial pump basically is Impala had a lower mortality, about 13%, 58% otherwise, brought down to 45%. But yes, there still remain higher limb ischemia and bleeding. So it should remain, because 14 French. Now, this field is also evolving. Once you go to the 9 French, and there are actually, we did a trial with the 9 French Impala, which is Magenta, and there are many other companies are coming in next 2 years, we'll have 9 French device. This is 14 French. ECMO is about 16, 17 French. So this probably will get better results even once our sheath size will decrease and less vascular and bleeding complication. The second is the CHIP score. We know the CHIP is complex high-risk interventional cases. There was a score established by the BCIS, which is the British Society, and then which was a 30-day endpoint. As you can see here, what they did is 7 patient factors and 6 procedural factors. Because you say, well, a patient is complex, but how do we quantify? So they came up with a very nice score. Not only the angiographic, but the patient, angiographic and procedural, as you can see here, 7 and 6, and divided the patient based on the no risk, low risk, intermediate, and high risk. And you can see the 30-day MACI in hospital happened anywhere from 1%, less than 1% to 20%. So clearly, more the factor, more than 5 leads to very high risk of the event. This was 30-day. Then we said, or in hospital, we said, why not we do it to the 1 year? And this is what we did. Took our database, which actually, as you know, Roxanne Maran does big quality control. All the data are very solid. They do all the assignment of the events and so on and so forth. So 1 year data from our database of the 21,000 patients, again in the various categories, which was part of the BCIS CHIP score. And we translated same factors and look at the outcome. And clearly, in terms of cumulative intervention of multiple, 1.7, 3, 6, and 12. So it makes sense. The CHIP score tells you your resource utilization, and of course, in the high-risk cases, you need to keep them in the hospital, more aggressive follow-up, and it is all aspect of the intervention. The score really translate into the outcomes. The third, with a drug-coated balloon in small vessels, or a drug-coated balloon actually should be overall. As you know, America was very far behind. The drug-coated balloon arena now finally is approved, came here. We are doing some trials, and in a small vessel, diabetic, this is the agent, which is the Boston Scientific, basically can be used for the native vessel as well as in the instant restenosis. Clearly, the goal there is the drug on the balloon, basically very nanotechnology. Once it inflates, it stays in the lyophilized particles with the drug, it stays in the wall of the intimal hyperplasia or in the endothelium, and does the same job of what the drug-coated stents do, but without the metal. And of course, all the drugs are being tested. Paclitaxel was the first one. We have been a trial with the sirolimus, and reason is why it is beneficial could be because short depth, no additional metal, decreased inflammation, no side branch closure, and there is no thrombosis, right? Because no stent. So the data basically is multivessel disease overall showed the height of the blue bar versus red bar, which is the drug-coated balloon versus drug-eluting stent. That was better outcome, 13% versus 4%. The study from China. The old trial of the Picolito in the small vessel, 2.25 to 2.75. 3-year data, again, in favor of lower TLR with a drug-coated balloon. And then, which really made to the FDA approval is the agent trial from the Boston Scientific with a drug-coated balloon against balloon angioplasty. And you can see TLR rate, target vessel MI rate, and all significantly better in the agent DCB compared to balloon angioplasty. So it's available now for clinical use. And as I said, drug-coated balloon, no stent thrombosis, and truly that happened. No stent thrombosis in this group of patients. So clearly, only thing is, it's available now, but very expensive. While the same device is about $800 outside the United States, it's $5,000 here. So we still have to wait for the appropriate reimbursement, then use will go up, but we started using and hopefully will use 1 or 2 cases of the drug-coated balloon agent in our cases today. So basically what is happening now, the interventional coming full circle. We started with the PTCA or balloon angioplasty, went to the BMS, DES, and now we are going back. How can we do a good results with a balloon only? And idea there is that you do a lesion preparation, and we have good results, then you do a drug-coated balloon. If not a good results, then you put the DES. And of course, this strategy, particularly for small vessels, diabetic, and patient with ISR is useful. Next one, imaging. The last 2 years, actually, in our field, interventional field, has been filled with many, many imaging trials, intracoronary imaging trials of using either OCT, IVUS, and which is the near infrared spectroscopy, looking at the yellow plaque, and of course, using your IFR and FFR, all of them. The first one was Renovate Complex PCI, basically, large 2,000 patients, they were randomized on the imaging guided versus angiography guided. 75% were IVUS, 25% OCT. And what did it show? Significant, almost half reduction in target vessel failure by using the imaging guided versus the angio guided PCI. And of course, you can see the stent thrombosis was 0.7 in the angio guided, was 0.1 in the imaging guided. And this will resonate continuously, that lower stent thrombosis in the imaging guided PCI. The second trial, Illumin 4, which basically was complex cases with the OCT guided versus angiographic guided. Of course, OCT will require more dye, more time, as shown here, fluoroscopy time, but outcome, but 2-part. One part was the lumen cross-sectional area, minimal stent area basically, which was higher in the OCT group compared to angio group. But if you follow these patients for 18 to 24 months, there was no difference in the outcome, except, again, lower stent thrombosis in this trial. The third trial in this field was October trial, which done in Europe, basically bifurcation cases, using OCT, and again, 1-to-1 randomization of 1,200 patients, showing benefit of OCT-guided PCI versus angiography-guided PCI, and shown individual numbers here. So consistently, again, lower stent thrombosis. So what happened is, then Greg Stone put everything together with this meta-analysis, which is just published in Lancet now. I presented in European Society last year, and basically put it together, I think, in one slide. All aspects of the imaging, you see there, imaging versus angiographic, just concentrate on the last section with the red. There is a benefit of any aspect of our intervention from 20% to 50%, 50% being the lower stent thrombosis in every aspect of our interventional cardiology. So it can make sense that using intracoronary imaging, and this is actually now, it's at 28% in the United States. Latest data are 28% PCIs are done with imaging, and we actually are about 28% also now. It's a 75% IVUS and 25% OCT. And of course, individual aspect very useful. To me, most useful is end of the procedure. So we'll see some cases, I mean, all cases will have imaging today, but many of them, you may not be able to advance these catheters pre-procedure, but we'll do it in the end. So in this imaging, we are very proud of a single center trial done by Annukini, the Yellow 3, which was a late-breaking trial last year in ACC, which is a continuation of Yellow 1, Yellow 2, and now Yellow 3, giving evolocumab 140 milligram every 2 weeks for 26 weeks, and a lot of very imaging parameters, OCT, IVUS, NIRS, and follow-up, and of course the angiogram were very good criteria, and this has the genetic component, which is being, at present, being evaluated and will be sent to the European Society of Cardiology. So basically the concept was that statin do work, or decreased lipid lowering works, but how does it work? There are some data in the past, but now they wanted to see, basically, we know the two factors. One, your lipid content of the plaque, and secondly, fibrous cap thickness. So what basically, those are the important endpoint on the OCT, that minimum fibrous cap thickness, cap became thick. From 70.9 micron became 97.7, and thin cap was 48 at the baseline, became 13% at follow-up at 26 weeks. Same thing with the NIR. Your lipid core burden index was 306 at the baseline, became 213. What I circled here, you see that not all patients responded. About the 24 to 20% patient did not respond in terms of these decrease in parameter, and they were looking into, and I know is looking with the Jagat and others, that what are the criteria, what patients do not respond, even to such a high dosage of the PCSK9, and LDL was 40. It was not the lipid. It is something else, and that hopefully we'll know that mechanism. This is an example of the thick cap, and of course the reduction of the plaque. You can see the yellow plaque shown here. Next one is the comparison. So IVUS versus OCT, and the name is OCT IVUS trial. So question is, which one is better? Very simple way, again 2,000 patients, and you can see here, of course, with a little more contrast with the OCT guided PCI, which we expect. What happened is, in the trial, they have very strict criteria of the stent apposition. And seems to be that IVUS guided stent apposition or stent, the parameters did better on the IVUS guided versus OCT guided. That is for the imaging point of view, but clinical outcome at 1 year is identical, 3.1 versus 2.5, and individual points are shown here. So it seems to be, it was non-inferior, which is on the left side, and of course not superior in any aspect, which is shown on the right side. So seems to be both are good, but as I said, the OCT is still used in about 20% of cases in the United States. Next one, functional complete versus culprit PCI in old. We always say, patient with MI, you do a complete revascularization, right? Multiple trials have shown that. We have been doing it. Question is, maybe in the old patient, you don't need to do it. Maybe just do the culprit. And this was the FIRE trial, which was done in Italy, that patients aged more than 75 years of age, patient presented with STEMI or non-STEMI. The question is, you do a complete revascularization, but they make it physiological guided, versus culprit only, and basically they found a significant difference. The complete revascularization was better, even in elderly patients. So clearly the all group, patients, complete revascularization better. They did an imaging guided, I mean physiologically guided, but most of the trial have shown in the acute MI setting, your imaging angiographic guided is good enough, which we'll learn from the complete MI trial. So basically is that complete revascularization, irrespective of the age, is a superior approach. And these are the individual endpoints in the FIRE trial. Then this is a very important topic. More so for our technical point of view, many of the interventional fellows and attendings here. So what we do usually when you have multi-vessel disease, We do a culprit vessel, then we discharge the patient and bring them for the follow-up is the stage intervention. That has been our practice. So we always did that. But then the whole question was, few of the events occurred in this follow-up period, which is 3 to 4 weeks or sometimes longer. So what is it true? Should you do all the multi-vessel disease, do PCI at the same time, or versus you stage it? And this actually was such an important question. 2 major trials looked into this question. One was the BioVask trial, which was done in Belgium, Netherlands, and Italy and Spain. Point was immediate versus stage. It's a complete revascularization. But question was only, do it at the same time or you do it at a follow-up? And basically showed about 1,500 patient, acute coronary syndrome, half were non-STEMI, 40% were STEMI, and basically showed the height of the blue bar versus red, the immediate complete revascularization was better compared to stage. So stage usually was about 26 to 36 days. Why? While patients were waiting, they came back for unplanned revascularization and more additional MI. Because these cases have a very vulnerable and hot plaque, and they develop in a non-culprit vessel event. So very clear cut that it should be done at the same time. But we don't change our practice by one trial. Well, to answer that cause, there's another trial from Zurich and Switzerland, the multi-star AMI. Question was the same. Patient with acute MI, with multi-vessel disease, should you do stage PCI? Or you do it follow-up, it was 37 days, stage was 37 days, other has the index procedure, most of them done at the same time, other one like 1 or 2 days later, but in the same hospital admission, again, decreased half event rate, 16 versus 8, and message was the same, non-fatal MI, unplanned revascularization was significantly higher in a patient with the, in the stage group compared to immediate group, no difference in mortality. So message basically is, your multi-vessel disease and MI, try to do it in the same hospital admission. Then the physiological trial, which is the FFR, IFR, there is a big controversy, which we just learned it. One is the FAME3 trial. You remember the FAME3 and then the defined flare and sweetheart. I'll share. FAME3 was the FFR guided PCI versus cabbage, in which PCI was lost to a cabbage in large majority of patients, but low-risk patient, low syntax score did better with the PCI, but cabbage was superior overall in the trial in all aspects, and that benefit continued up to 3 years, and individual endpoints are all here. So seems to be that cabbage allotment of the cases done on the multi-vessel disease, left main was excluded, versus FFR-guided PCI, that the cabbage continues to do better for 3 years. Now, what will happen? 5-year data, we'll see. So then the big controversy happened, which we know that FFR and IFR, which have been in the early trials, both were equal. Immediate endpoints of 1 or 2 years were identical. But this, once you get to the 5-year follow-up, you see FFR, IFR, which original trial was the defined flare, and IFR sweetheart, 2 trials. So 1-year follow-up was not inferior, but I want to bring point to this. Revascularization was 48% with the IFR guided and 53.4% in FFR guided. If you have my top 10 lecture 4 years ago, I did make the point that FFR guided PCI did 6% higher revascularization, and this is all available on our top 10, the CCC Live. At that time, I mentioned that 1-year outcomes were identical, but whether this 6% will translate into a different outcome at later on need to be seen. So they see what happened. This is the 6%, and basically what happened now, that while 1 year was good, now all of a sudden there is a difference in mortality of 3%. 9% in the IFR group and 6% in the FFR group. And then second trial was sweetheart. There was also kind of signal. So this led to the major paper in the European fast track on the European Heart Journal, putting both of them together, IFR sweetheart and defined flare, and basically showing that there is a difference in mortality in favor of FFR. This is the first time we always felt both are equal. IFR people do simply because no need to give any vasodilator, less side effects. So this was a shocker, but the question comes, and these are the individual endpoints. Look at the MACE, all-cause mortality. There was no difference in unplanned revascularization. Only thing is it because of higher complete revascularization in the FFR group? Although we say that higher complete basically makes sense in the ACS patient, not in the stable. But remember, in this ACS patients were about 45%. So they were both. So question is why this difference, but this is what it is, led to the major publication in the European Heart Journal just a few weeks ago. Then comes down to the last two, which I would say interventional, finally are happy. Happy because we have some positive trial. Remember Orbiter follow-up with the same investigator of the basically blinded investigation of the optimal therapy for stable angina. They did Orbiter 1. Patients sham procedures and some had the stent, then follow-up with the 6 weeks. So these guys said, let's go to next level. We always say PCI does as good as a medical therapy, but PCI and medical therapy are combined. What if we stop anti-anginal medication in patients with stable disease, and then just get the benefit of PCI against medical therapy? So this was a very innovative concept. I'm sure it will not be approved by any IRB in America. And you still do the angiogram. Patients still getting the catheter injected. They would not know whether they got a stent or not. But all these patients, that was the concept, and all have a CAD, positive stress test, and very innovative the follow-up. What they did is they taught the patients to report their symptoms. So subjective, patients themselves reported their angina symptoms. They taught them that daily log. So you don't have to worry about hiring the research coordinators and so. The patients submitted their data. So after the initial washout period, they got our testings, then randomized to the PCI or placebo, and followed these patients for 12 weeks. And of course, each of these was added, and basically, you see about 300 patients. And what did we find? PCI alone, without medical therapy, had a lower angina episode, mean anginal episodes, mean daily anginal medication, and better treadmill time. And lastly, stress echocardiographic scores were better. So showing that unadulterated, pure PCI did better than your maximum medical therapy in this group of patients. Now, also, you see, spontaneous MI, just in this 12-week period. In the other group was 6 cases. Of the 150, developed 6 spontaneous MI. You say, well, periprocessor MI were also 4. But we know that. Periprocessor MI has a different prognosis than spontaneous. Why? Periprocessor is done in the hospital. They don't have the event rate. So clearly, only problem will be, just like Orbiter 1, I don't think we'll have a long-term data. You know why? In Orbiter 1 cases, those 100+ cases, they all got a PCI after 6 weeks. So whether all will get a PCI after 12 weeks, we don't know. But it need to be seen if we could get a pure data or the long term in this group of patients. And of course, now. So clearly that I think the new paradigm, you can make it. That doesn't have to be that every time we do a maximum medical therapy, although guideline does not still say maximum medical therapy stable patient and PCI only for refractory symptoms or side effect. But you could make it now that maybe without medicine, initial PCI may be better, maybe. But only problem is the cost, resource utilization, and capacity, big thing. Because we know rough data are, any cardiologist sees the patient in the office. Of 10 patients, how many come to the cath lab? 1. 9 of them are managed medically. If you can imagine, of those medical therapy, if you start making them PCI, it's not appropriate at present, but question is if there is something continues to better data, maybe something to be seen. But if happens, there will be a tremendous increase in our interventional volume, which we won't mind it anyway. Okay, the last one, another positive trial, which is very controversial. Anytime I present with a lot of, the preventive PCI for vulnerable plaque, which is the PREVENT trial. So PREVENT trial basically was done, as you know, in Korea. And we always have talked about that you have vulnerable plaque. Should you seal it? And particularly when we have the drug-coated, when we have a bioabsorbable stent, BVS. So this is how it started, that identify the vulnerable plaque and then coat with the DES or BVS and then follow them compared to maximum medical therapy. Now this was based on a trial which I presented 2 years ago here, combined OCT FFR trial. Now what was the trial? Trial basically was the patients who were FFR negative. FFR was more than 0.8, but have a vulnerable plaque on OCT. Their event rate was 26% versus 10%. Significant compared to 10% was those who got the stent. So basically, unstented, but vulnerable plaque with a thick cap had a higher event rate at follow-up compared to you put a stent in a FFR positive lesion. So that was basically the concept was. And this led to the definition of vulnerable plaque with the MLA, plaque burden, TICFA, and lipid rich. Again, 1,600 patients. It was took many years to complete because of various issues with the COVID and so. What they found, the 2-year endpoint was 0.4, because these were the low-risk cases. It was 0.4 after stent, 1 year. Problem of cardiac death, target vessel MI, TVR or hospitalization for unstable angina was less than 1%, and it was 3 times higher if you did not do it. And then, of course, the follow-up of other event rates on the right side showed it. These are the individual endpoints. So it was the first trial. I would say more of a mechanistic trial. I know the outcomes were a little different, were positive, but it's kind of a concept which we all have been thinking about for the years, that whether sealing the vulnerable plaque will help it, and this actually answer to is yes. Now look at the conclusion in the Lancet. Given the PREVENT is the first large trial to show the potential effect of focal treatment for vulnerable plaque, these findings support consideration to expand indication for PCI to include non-flow limiting high-risk vulnerable plaque. I would say this was to a little more aggressive conclusion. I mean, the wishful thinking, although we won't mind it if ever happens, because besides on the Orbiter 2 data, this one will make PCI multifold increase. But we always say, one trial doesn't change our practice. Now we have 3 trials are going on this aspect. One is combined intervene trial, chronic coronary syndrome, experimental PCI or conventional PCI based on the OCT with a 2-year outcome. Second is interclima trial, interventional strategy of the culprit lesion based on the OCT criteria. Again, 1,400 patients, incidents in 2 groups. And the third one is favor 4 MI trial, 5 AMI trial in 1,000 patients. And this is the event-driven trial. So once we have the data from these trials, and they also corroborate what was the finding of the PREVENT, then I would say the conclusion of the Lancet, the authors will make sense. So with that note, I complete our top 10, and let me put it together, which I call it the central illustration, which is coined by Dr. Fuster and become charge of the JAC. Put everything together. It clearly was that if you cannot show it in one slide, your entire paper means you don't know the subject. So this is, have they changed my clinical interventional practice in 2024? So I did it, I had a little modified way with my more even simpler than complex central illustration by Dr. Fuster journal. ECMO in cardiogenic shock, 2 thumbs down. IFR versus FFR at 5 years, IVUS versus OCT, plus minus. I would say that both are good, although IFR you can make it a clear-cut 1 thumb down. The IFR versus FFR at 5 years, IVUS OCT said. Then cabbage over FFR guided PCI, BCI chip score, PCSK, increased cap thickness shown by yellow is 1 thumbs up. Of course, really will make it better with the PCSK data once we have the clinical outcome or some genetic analysis. Then drug-coated balloon in a small vessel and diabetic, imaging guided PCI, Impella in cardiogenic shock, 2 thumbs up. Then DCB in ISR, immediate versus complete revascularization, ST elevation, and in MI and elderly patient, all 3 thumbs up. For last 26 presentations, I always stopped at the 3 thumbs up. But I would say the first time in my own history of top 10, I have a 4 thumbs up to PCI with no meds versus medical therapy, and PCI for vulnerable plaque versus medical therapy. Maybe controversial, but that is what we have the data, and we need to enjoy make it a better interventional and survival. Have they changed it? This is our number. If you see at Sinai, ECMO, Impella numbers on the top, FFR, IFR clearly has gone down. OCT, IVUS numbers are there, 28% for us. Drug-coated balloon has just started. And in-hospital stage PCI, which we rarely used to do, now started doing some cases with at the same time, change our practice based on the data is the goal. And with that note, I'll stop it. And these are our top. We continue to provide the best result with the highest volume of the interventional cases in the New York and perhaps in the United States. And thank you very much.